So let me just spotlight. Welcome to Sheri. So Sheri Hundseth is the Director of Indigenous Relations and Community Engagement, Providence Healthcare, and is now going to be talking on the effects of colonialism on Indigenous wellness. So thank you very much, Sheri, for joining us, and I will give you the floor.
Thank you for the introduction, Ben. It's nice to see everyone here. Tansi, my name is Sheri Hundseth. I am Métis, and I am an uninvited visitor from Region 1 in Northern Alberta, Lac La Biche, and Treaty 8 territory. And I acknowledge with humility and gratitude that I live, work, and learn on the traditional, ancestral, unceded lands of the Musqueam, Squamish, and Tsleil-Waututh nations. This presentation, we're going to be talking about the effects of colonialism on Indigenous wellness and engaging your brand on a path to reconciliation. I'm going to talk a little bit about honoring territory, and the reason I'm going to chat about this is because we often get many questions on this here where I work at Providence Healthcare. One of the number one things to think about here is that it is an act of making us visible in our own territories. It's an act of respect. It's an act of anti-racism and an act of anti-colonialism. And it's truly an opportunity for you to reflect on your relationship and to increase your own knowledge and commit yourself to reconciliation as well. I know that in the opening videos that were shared for Brand Battle, they had shared one of the sites where you could actually see the languages, arts, heritages, and the lands that you're on. Really great if you can actually take a look and start doing your own research on this if you haven't already. Today, I really want anyone who is participating in this that is Indigenous, although this presentation is meant to support truth, justice, and reconciliation, it may trigger some unpleasant feelings or memories, so please take care in this. For anyone who is non-Indigenous, this presentation is meant to be a part of ongoing unlearning and learning about different situations that have happened for Indigenous peoples. Some of these stories that I'm going to share today actually will trigger feelings of shame, guilt, and sadness. Please accept this discomfort and take responsibility for your own positive contributions to move past this. Today, again, we're going to talk about coming away with a bit of more of an understanding of cultural safety and humility. I know that everybody who is in this presentation may be at different levels of understanding within this, but I believe in every situation you can learn from. So learn ways to identify culturally unsafe practices and what you can do to address them. Understand some of the impacts of colonialism on Indigenous wellness. I will have some stories to share with you here, and engage your brand on a path to reconciliation as well. And then to share ideas on how you can engage and or co-create with intention to be an ally to Indigenous peoples with whatever strategies and initiatives you have. So a little bit around context with the presentation that I'm going to be sharing with you today. First Nations, Métis, and Inuit people have an extremely rich history of wellness that extends back in time for many thousands of years. First Nations practiced a mix of hunting, fishing, and gathering foods, and enjoyed good health and wellness due to a lifestyle that was really active. It was based on healthy traditional diets, and it was enriched by ceremonial, spiritual, emotional, and healing practices. With the arrival of Europeans, there was a marked change of course in the First Nations wellness journey. First Nations health and wellness was truly disrupted through a process of colonization and oppression. Tactics and policy initiatives such as Indigenous residential school system and the Indian Act and Indian hospitals truly pulled apart everything that was near and dear to Indigenous wellness. These institutions created a legacy of trauma and health, social inequities. First Nations self-determination was completely undermined, and decisions about health and wellness were made for them, not with them. As a result, First Nations continue to bear a heavily disproportionate burden of disease or health disparities. And today, colonial trauma and oppression takes place within the health system through culturally unsafe and discriminatory care. In response to the overwhelming challenges and tragedies our people and communities have had to endure, there have been a number of inquiries and investigations that have been completed, resulting in hundreds of recommendations. I've highlighted 3 of them here in the images that I have. There are quite a few that have come out now, and I will describe a few more, or 2 of them in a little bit more detail. The final report for the National Truth and Reconciliation Commission, the final report for the National Inquiry into Missing and Murdered Indigenous Women and Girls, and In Plain Sight, the report from the investigation into anti-Indigenous racism in the health system. All of these speak to the survival, dignity, and well-being of Indigenous peoples, and it's increasingly a matter of law, social awareness, and justice. In terms of social isolation from an Indigenous perspective, when we're looking at this, Indigenous peoples are actually considered at a high risk of experiencing social isolation due to a number of factors, including racism, marginalized language, culture, poverty, and historic negative experiences. Stats Canada did a study just recently and detailed that 37% of Indigenous participants experienced job loss or reduced work hours compared to 35% of non-Indigenous patients or participants. 36% of Indigenous participants reported that the COVID-19 pandemic had an impact on their ability to meet financial obligations or essential needs, compared to 25% of non-Indigenous participants. That's an 11% difference. Among those who experienced job loss or reduced work hours, 65% of the Indigenous participants reported a strong or moderate financial impact, compared to 56% among non-Indigenous participants. When we're speaking about mental health, Indigenous women in particular were impacted. 46% reported that their days are quite a bit or extremely stressful, and 48% reported that symptoms consistent with moderate or severe generalized anxiety disorder. In 2016, 47% of those living in families headed by an Indigenous person were unlikely to have enough liquid assets and or other private sources of income to sustain themselves for a period of 2 months without employment income. The challenges with COVID-19 and job loss have greatly increased this number. 22% of Indigenous participants feel that people in their neighborhood are being harassed or attacked often and or sometimes because of their race, ethnicity, or skin color. This is compared with 11% of non-Indigenous participants. And in Vancouver, almost 2 of 5 homeless residents are Indigenous, even though Indigenous people only make up 1 in 20 of the population. Speak a little bit about cultural safety. The concept of cultural safety arose from the colonial concept and context of New Zealand society. And this came in response to the poor health status of the Maori, the Indigenous people living in the area, insisted that service delivery needed to change profoundly. Nurses actually began a process of self-examination and change in nursing education, which was prompted by the Maori nurses. It's really, truly needs to be identity affirming, to be able to go somewhere and have your rights upheld, to be able to have self-determination, to be able to have some decision-making capability in traditional medicine, to have science and care received without discrimination, to be able to have the right to highest standard of care. A culturally safe environment is the desired outcome and can only be defined by the Indigenous person who's receiving care in a manner that is safe and doesn't profile or discriminate against the person, but is truly experienced as respectful, safe, and meaningful communication and service. What's been interesting to me working at Providence Healthcare is oftentimes we share this information and people come up with ideas and great ideas, but we often hear from the patients that we're working with and that we hear from that things are being done to them, not with them. They don't have any say in the care that they're actually receiving. To be culturally safe requires positive anti-racism stances, tools, and approaches, and the continuous practice of cultural humility, ensuring that you actually are including Indigenous people in the process. Cultural humility, another concept that needs to be widely accepted. You can't just say the words, you also need to take action. Cultural humility is truly a reflection of learning and unlearning. Even as an Indigenous person, I am continually learning in this space. You have to probe one's biases, be honest with yourself. How does it show up in my behavior? What am I willing to do? What am I not willing to do? What discomforts am I going to experience? What will I experience to show equity for others? What am I actually willing to give up so that other people can experience the same things that I can experience? Putting yourself at the same level as someone else and understanding someone else's experience. Just as it's an interesting part of this concept, I'm Métis. I often have been told that I can pass as white. I experience different things than some of my relatives do. And it's very apparent in different situations, apparent to the point where I'm actually embarrassed, right? And as a child, because I could pass for white, was often told not to share with people that I was Métis because it would be damaging for me, that if I did, that I wouldn't experience the same comforts. Humility is a difficult concept for many people to personally grapple with, and how it is defined may contribute to the actual challenge. Western definitions will describe humility as freedom from pride or arrogance, or a modest or low view of one's own importance, which both sound like criticisms. And what do these criticisms often elicit? But a defensive or a negative response. I find that sometimes the discomfort with humility is there because there's a misunderstanding that leads people to think of humiliation instead. It's harder to grow and learn from that place. A more positive way to look at humility is to understand that on a certain concept, idea, field of study, or state of being, your understanding is lower for whatever reason. That's the tie. That's the lead into understanding cultural humility. Humbly acknowledging yourself as a learner when it comes to understanding another person's experience. So what is it to be culturally unsafe? The interaction between carer and person seeking care or services is unbalanced. The power dynamic still favors the carer. Here, working within healthcare, we see that quite often. People will often defer to people that are much more educated, right? You hear doctor, and it becomes a place where people are afraid to ask questions. The health system has actually perpetuated through ongoing colonialism. A person feels or senses that they're being judged or stereotyped. They're disempowered, they're discriminated against. The person seeking care or services feels that they cannot raise questions or issues because they don't know how to ask the questions. And they're also at risk of being labeled or denied good care. We have a process of self-identification within the hospital so that people can actually receive Indigenous specific services. And oftentimes people will actually say they fear identifying as Indigenous because they feel like their services will be diminished as a result of. The Declaration of the Rights of Indigenous Peoples, UNDRIP, it's a universal framework of the minimum standards of survival, dignity, and well-being for Indigenous peoples worldwide. It's the overarching human rights framework that directs governments and societies on how to recognize and implement human rights and self-determination for Indigenous peoples. Since 2019, the BC government has committed to adopting UNDRIP as a legal framework for the province, including healthcare. And it is recognized as the framework for reconciliation. There are actually 46 standards for the survival and dignity and well-being of Indigenous peoples. However, there are many people who are still unaware of the legislation and their role in it. There needs to be expression given to this and understand the relationship to cultural safety and Indigenous rights. The In Plain Sight report came out in 2020. There were over 9,000 Indigenous respondents to this. And this study began as a result of some information that was provided in an Indigenous Cultural Safety course. There were bets being taken at a hospital about how drunk Indigenous people were when they were actually coming in. This had to be investigated, and 24 different recommendations for human rights approach came out for healthcare here. 10 recommendations talk about improving accountability, legislative changes, governance structures, standards, complaint processes, physical spaces. Behaviors that needed to change, 9 recommendations came out in terms of including Indigenous people in leadership positions and as health professionals. Belief system, really talking about mandatory health professional education, making sure that people are aware of Indigenous history and health, knowing that these things have happened and are continuing to happen. In terms of the in plain sight study, there were a number of stereotypes that were discovered along the way from the 9,000 Indigenous participants that filled this out. The top stereotypes that came out of this is that Indigenous people coming into healthcare facilities were less worthy of care. They were drinkers, alcoholics, bad parents, that there was sexual availability, disposable as human beings. This really truly shapes discriminatory treatment. We all have a bias and mental shortcuts. We know this. We assume things about people when we see them. When we actually do that to other human beings, we actually see discriminatory treatment, abusive interactions, denials of services, ignoring, shunning, inappropriate pain management, medical mistakes, assumptions of alcohol abuse, misdiagnosis comes up quite a bit. And the vast number of pharmaceuticals actually come from Indigenous knowledge. So knowing that and knowing that there is a history of Indigenous belief in healthcare that's actually being denied has deeply impacted Indigenous people. Many other systems actually follow suit. Life expectancy is lower for Indigenous people. Infant mortality is lower for Indigenous people. It just shows that there is a disparity, and usually because of assumptions that they are bad parents, it shows, instead of understanding the fear of coming in for care, that they're bad parents. So there is a necessary shift. In the past and present, the approaches and mindsets have really been steeped in colonialism around privilege and supremacy. Beliefs and behaviors that result from this are racism, profiling of people, discrimination, prejudice, fragility comes into play. And the outcomes truly are poorer outcomes for Indigenous peoples, systemic racism and discrimination. The approaches and mindsets that we're hoping to come out of this are that Indigenous human rights are considered in everything that's happening, that beliefs and behaviors, cultural humility, anti-racism result in outcomes such as equity, cultural safety, and true reconciliation. Ways to recompensate, restore, and take active steps to actually correct the behaviors that are happening so that an Indigenous person actually feels safe regardless of where they're going in society. So in terms of cultural safety and human rights, while I'm coming from a healthcare lens, this doesn't just apply to healthcare. People deserve to be able to access services, whatever services those are, without discrimination. The amount of times I've heard Indigenous people say they walk into a mall and are followed around because they're Indigenous. They're treated differently. They're asked if they have enough money to be able to afford coming into a store. The access to and use of ancestral medicine, ensuring that people have the right to their spirituality, that they can actually actively pursue spirituality and, culture in terms of having to hide that without being watched. I'll talk a little bit about some of the engagement things that I and my team do to encourage Indigenous patients to share their experiences and to feel safe. In terms of this, some of the stuff that we do is outside, and we often feel like we're in a fishbowl being watched when we're actually running any cultural events. Cultural impacts of care. I'm going to speak a little bit about some interactions that happen. As Euromed info describes, all cultures have systems of health beliefs to explain what causes illness, how it can be cured and treated, and who should be involved in the process. The extent to which patients perceive patient education as having cultural relevance to them can have a profound effect on their reception to information provided and their willingness to use it. Cross-cultural understanding can impact the consultation with a health professional. You may find that a patient struggles to define symptoms or explain it in a way that actually imparts the feelings or sensations of the symptoms. A lot of Indigenous elders who have been through residential schools or Indian schools may actually delay or avoid seeking care, letting things get worse because they actually fear discrimination in their healthcare encounters. They've been taught in those institutions that they are a bother, they're an inconvenience. They've internalized that, and it can be displayed at appointments as an avoidance of eye contact, speaking more softly, not speaking at all, and or describing extremely painful symptoms as not bad. If you aren't aware, you're going to miss this context, which impacts the entire encounter and further care afterward. If you're not taking the time to address it in mutual acceptable ways, there's little wonder that adherence to treatment can actually be an issue. I'm going to share with you a bit of an example in terms of understanding. By missing clues or by misunderstanding a patient's cultural viewpoint, it's possible for healthcare providers to unintentionally offend or place the diagnosis, adherence to treatment, and or health outcomes at risk. So just giving you an example here, Rupert Ross was out in community and stated, knowing that a lot of old people gathering blueberries at that time of year to raise a little cash, speaking to an elder, I asked her how the blueberry crop was that summer. She immediately replied, "Oh, I was out at the garbage dump last night and there were 16 bears out there." She was communicating what she needed to communicate to him, but it takes context to understand what she was saying. There are always intercultural differences in communication. She and her response to his question is one that locals in the area would understand, but would mystify someone not from the area. Her answer to his question can be paraphrased as, "The berry crop is bad." And she expressed her response through allegory. When berries are plentiful, the berries would be out eating berries. When the crops are poor, the bears seek out other food sources, in this case, the dump outside of the community. The key is to practice humility when listening and interpreting, and actually asking questions. Follow up with unbiased information seeking questions to actually learn more about what people are speaking about. We work really closely with a number of the patients here at Providence Healthcare. The team and I have a number of ways of working with patients. I'm going to share a little bit with you from one of the stories that was shared with us during patient journey mapping. We work with a live recorder that actually draws maps while we have sessions so that Indigenous patients can actually share their experiences within the hospital. This patient was generated by a female patient in her mid-60s who visited the emergency department, cardiac, surgical, and the ICU. She stated that people need cultural education. Most Indigenous women are modest. It's important for staff to remember to be mindful of a patient's dignity and privacy. During her time at St. Paul's Hospital, she found a number of interactions to be very disrespectful. She felt that any time she needed to ask for anything, even small things like a snack or a blanket, I was made to feel like it was a big deal and that I shouldn't bother the nurses. In the 65 days that this woman stayed at St. Paul's Hospital, she was only offered help to have a shower 2 times and was only able to wash her hair once. It may seem really benign, but I'm going to share an experience from an Indigenous mental health patient. He was in his late 20s. This just happened 6 months ago and it came through our complaints area. He was diagnosed with schizophrenia and several other concurrent disabilities. And he, as a young person, had been part of the millennial scoop and was actually taken away from his family and was trying to reconnect with his indigenous culture, including language. He presented back at the hospital during an episode, and the charting notes that were written down were that this patient was speaking in tongues and making up songs. In fact, he wasn't speaking in tongues. He was using words from his Indigenous language, and he wasn't making up songs. He was sharing an Indigenous language song with cultural and spiritual significance to him. Many Indigenous nations believe and know that ancestors and spirits can visit individuals when they're struggling and provide them with guidance. This highlights the need for increased chart audits by Indigenous cultural safety experts who can actually pull out the learnings for staff. The charting notes underline that some potential bias, which may seem benign, but I'm going to show you how these benign statements can actually become devastating in some circumstances. Some of you may be familiar with these stories, the devastating consequences. Back in 2010, an Indigenous man, Brian Sinclair, died in 2008 of complications from a bladder infection after being ignored for 34 hours in a Health Sciences Center emergency department in Winnipeg. He arrived at the emergency department after being sent over by his physician at a community health center for a catheter change, something that should have been very simple, but something the community center was unable to assist with. So he arrived by taxi with a letter from the nurse explaining what he needed to have happen. Brian was seen on camera talking to the triage aide and seemingly being asked to wheel himself to a different spot. And crucially, the aide did not collect the necessary information that would initiate a chart for Brian. Over the next 34 hours, Brian would speak to various staff and security several times. He was visible the entire time, but still not being admitted despite obvious signs of growing distress due to his worsening condition, including vomiting at one point. Each time he interacted with staff, assumptions were being made. For example, that he was discharged and waiting for a ride, or that he was drunk and sleeping it off. At one point, a fellow patient that was sitting in the emergency room expressed concern about his condition. He still wasn't admitted. And again, despite obvious signs of distress, they left him there. The next day, another person who had seen Brian there the night before raised the alarm about him, having seen Brian in the same position as the night before. Security approached him again and discovered that he was dead. They rushed him in. And tried to resuscitate him, but he could not be revived. Rigor mortis was already setting in. Brian's cause of death was acute peritonitis. At subsequent trials and inquests, the stereotype of the drunk Indian would come up over and over again. Brian's case was supposed to teach the health system how to avoid preventable death like this again. It did not. In 2020, Joyce Etchiquan, a woman who died in September 2020 while in care at hospital, where she was seeking care for epigastric pain. Joyce had pain on and off for 2 weeks prior until it became constant, driving her to seek help. She had a significant medical history, including diabetes and severe cardiomyopathy, leading to heart failure. In August 2020, Joyce sought care at the same center for pain and was dismissed as a drug addict, described as having a tendency for manipulation. This label in her charting notes would impact her care in September. During her September encounter, as Joyce's pain continued, she grew agitated and was mistaken by the gastroenterologist for being in withdrawal from narcotics and cannabis, an assumption that would not be supported by evidence. The only narcotics Joyce was taking at the time were prescribed at therapeutic doses, and the autopsy would confirm that the drugs in her system were within acceptable ranges and were in trace amounts. Over 2 days, Joyce complained of many symptoms and her body was noticeably swelling. She was physically restrained using 4-point restraints and an abdominal belt. And she chemically was restrained with Haldol. She was left unsupervised, laying in a position which allowed a dangerous buildup of fluid on her lungs. The medical circumstances aside, as Joyce cried out in pain, she was verbally abused by nursing staff who called her derogatory names based on racist and misogynist assumptions. They talked down to her, and all of this was captured on a Facebook live stream that Joyce had started so she could beg her family or friends to actually come and help her. Joyce died of a pulmonary edema as a result of converging factors, and the coroner actually indicated racism as a contributing factor to this. How do I, as an Indigenous person, feel about what I just summarized here with these different exchanges? I'm sad, obviously. I feel very emotional. I'm disappointed. I'm angry. but it also leads me to very, very determined. I feel all of those things. It grows and it morphs and it recedes and it dissipates. It depends on where my heart and head at. And then I feel determined. I feel responsible in this job, in what I do for a living, to reach out to people across healthcare and teach them, to mentor them. People that aren't in healthcare, to teach them, to mentor them, to help them become better. Because the life and well-being of a patient should not depend on the biases of their health practitioners. So how do we identify cultural unsafeness? There are definitely blatant remarks and discrimination. Those are really easy to spot, but what's harder to see is the subtle stuff, and it happens all the time. Microaggressions maintain that power imbalance and perpetuate the lack of cultural safety for Indigenous patients, residents, their families. They're exhausting to BIPOCs because they aren't obvious to all, but they are to the people that they're aimed at. Policies or procedures can read fairly innocuous unless you actually see something which could inevitably create a barrier or trigger or a negative experience. Inflexible policies or procedures can also create moral distress for providers and practitioners, especially if they are Indigenous. Challenges with uptake on all of this. Personally, a lot of people talk about truth and reconciliation fatigue. We've heard about this for years. When are we going to stop hearing about it? Or where do I even begin? Or I'm so busy at work, I don't have time to take this on as well. Institutional, we hear a lot of a lack of investment, that the policies, procedures, and practices can't support or can't be changed, or there isn't time to change those things. Or there is a poor corporate culture as well. So I'm going to start to talk about what not to do very specifically with Indigenous peoples as a start. Please don't use the possessive. I hear this all the time in presentations. Our First Nations. It's not appropriate. They aren't owned by anyone. They are their own nations. Please don't use the word our. Cultural appropriation, adopting or exploiting a culture by a more dominant culture. You know, and you see different things happening where people want to identify as or with. I've seen so many Indigenous Halloween costumes. Tokenism, the practice of making only a perfunctory or symbolic effort. Thank you for wearing orange t-shirts if you were able to today. Please understand what those orange t-shirts mean and why you're wearing them. Saviorism, centering oneself in overt and subtle ways. This comes to the point of many patients saying things are done to us rather than with us. Yes, we understand that you have really great ideas on how to do things, but Indigenous peoples need to be a part of finding out what the solution is. Optical allyship, making a surface level statement, but actually not taking any actions at all. Many people say that they're not racist. If you're not doing something about it, then are you or aren't you? Cultural loading, an additional piece. We work really closely right now. We're building a new St. Paul's hospital in the downtown east side. And often what we see is some of the contractors and subcontractors asking us about ways that they can actually work with Indigenous peoples to support days like September 30th coming up this Friday. Their number one ideas were on hiring somebody to teach them, somebody Indigenous to teach them about September 30th on the day of. That's not an Indigenous person's work to do. Please don't hire an Indigenous person on the day that's actually meant to honor them. What you can do, really important factors in all of this. Things to consider. Please continue on with your own education. Have courage and challenge yourself and challenge others. Be okay with not knowing and asking questions. Be okay with being vulnerable. Be okay with your own vulnerability around this. Participate in community events if you know that something's happening. If you know that there's a way that changes can come into play. Make a space for Indigenous voices. I've worked with a few people who often like to talk over me when I'm actually sharing information and aren't actually listening because they feel like they've taken enough cultural safety courses to know. I watch this happen often with our elders. many of whom speak very slowly or think before they speak and aren't given the space because they're actually thinking. Be okay with small steps. Treat Indigenous cultural safety as a professional competency. Here at Providence Healthcare, we're making it part of something all of the medical staff need to do in order to have competency at it, in order to treat patients with respect. Embed this into your ethical framework. Take formal courses. Take a look at professional development. Embrace critical inquiry. Ask questions. If you see something that isn't okay, speak up about it. If you see somebody being discriminated against, or if something is twinging for you as that doesn't seem right, then speak up about it. Listen, ask questions, and support Indigenous businesses. I've encouraged many of those organizations that reach out to me to find out what to do in order to support Indigenous people. If you're buying an orange shirt, buy that orange shirt from an organization that actually supports Indigenous people and actually puts the proceeds towards Indigenous people as well. Really important to engage in critical inquiry, right? This process can often involve feelings of anger, grief, disappointment, and resistance, but this process also offers new windows on the world. You have to feel uncomfortable, not knowing, so that you can actually move outside of your comfort zone and become into a more comfortable place, knowing what's actually happened. So, in terms of the information that I've shared with you, how can brands engage and co-create with intention to be an ally and to support the development of Indigenous-led initiatives and strategies? Talk a little bit about what's happening here. What I'll ask is that you start here. There are so many reports. Embarking on this work may feel really challenging and or intimidating, but there is a path forward. There are many successive reports, studies, standards that have been endorsed by Indigenous people, that have been endorsed by the federal and provincial and other levels of government across the country. Take a look at In Plain Sight. Reclaiming Power in Place, the Missing and Murdered Indigenous Women and Girls Inquiry. There's 231 calls for justice in that report. Red Woman Rising, they've come up with 200 key recommendations. The Truth and Reconciliation Commission, 94 calls to action that there are so many people that are still unaware of. And UNDRIP, which I spoke about beforehand. This really truly is the base level of human rights standards. Here at Providence Health, we've taken those reports very seriously and put reconciliation in as a foundational principle to the organization, ensuring that it impacts and influences every part of the strategy that we have here. It works into our mission, vision, and values. It is embedded in the ethics standards. It is now a part of the sustainability that we work with, and it has become a part of our person and family-centered care as well. Within reconciliation, we have an Indigenous Wellness and Reconciliation team that works for the organization. There are 17 of us now. We have an Indigenous Wellness and Reconciliation Action Plan. This has been designed to address systemic and anti-Indigenous racism within the healthcare system and to advance Indigenous wellness, reconciliation, and human rights. Here at Providence Healthcare as well, very specifically to the area that I work in, which is Indigenous relations and community engagement. We embed engagement that we have done with Indigenous peoples in every single thing that we do. Feedback that we've heard is, please don't do this if all you're going to do is tackle the artwork, because that's often what people see. Instead, we're embedding it in everything. We're building a new St. Paul's Hospital and now an Indigenous Wellness and Welcoming Center that's 9 stories high right across the street. Within this, we are tackling the artwork. We're looking at the clinical spaces, making sure that they are culturally safe for any Indigenous person walking into the hospital. Taking a look at clinical processes. We're building an all nations sacred space so that people can actually perform ceremony within the hospital. We are now building a medicine garden in that space as well. And all of the landscaping is taking account for what the knowledge keepers that we work with very closely have in mind. We also look at the current services that are being delivered to Indigenous patients, the spaces, the buildings, the supports, making sure that we're actually adding value and building capacity. A lot of the Indigenous patients that we work with really report to the fact that they would like to see more familiar faces, more Indigenous people actually working within. And we're also taking a look at corporate operations and innovation, so research and procurement. In terms of research, data about Indigenous people should belong to Indigenous people, and Indigenous people should have the right to decide how that data is being utilized. Procurement, ensuring that in every project that we work with, Indigenous businesses are considered as one of those mainstays to be able to purchase those supplies from. Recruitment and retention, ensuring that there are culturally safe ways to do those things as well. Data and policy, making sure that people are feeling comfortable with the policies that have actually been created. Our engagement philosophy here with Indigenous Wellness and Reconciliation is to really make sure that we meet people where they're at. I don't design anything that we're doing around engagement until I've spoken with the people that we're going to be working with to ensure that we're doing it in a way that works for them. We follow their cultural, community, and engagement protocols, and I have to recognize that I am likely not going to hear what we want to hear. Baby steps all the way forward, and sometimes we regress. Different people are experiencing different things, and we need to hear the information that we're hearing so that we can actually improve upon it. Making sure that we're building a two-way capacity. You have to honor people for their time as well. Each patient that works with us is given an honorarium. Any elders that we work with are monetarily provided for. We invest in our organizational capacity so that they can actually do the engagement themselves as well. We work with a couple of organizations who actually have learned how to do engagement through us, and we support them monetarily to do engagement in the downtown east side as well. And we recognize that their input is an investment in our learning to make this better healthcare. We're interested in being in an authentic relationship. Another thing to note here is this can't just be a one-time thing. This is an ongoing process. As in any relationship, you have to continue to focus and build on it. Building trust takes time. 500 years of colonialism isn't going to disappear in a day. We have to be really honest about what we can and cannot do around this as well. So when people are asking us to do different things, if it isn't a capability, then we have to let them know why. We have to let them know that we are still addressing it and listening, and share with them what we can actually do. So we need to actually show what we've done with the feedback that they're providing. All of the change impacts have come from Indigenous patients. We share the information with them as to what they've suggested and what we are actually doing so that they know. Methods of engagement, we work really closely with host nations. We have worked very hard to build these relationships. And so we meet with them on a regular basis. Patient journey mapping. We've worked with now a total of 34 patients who have given us 2 hours of their time. We have recompensed them. We are taking all of the feedback that they provide about Providence healthcare sites and ensure that that is put into a report to leverage changes that need to happen. They approve all of the maps that are drawn, all of the feedback that is given, and the final reports that are shared with our executive leadership team and our board members to ensure that these changes can actually take place. We have a number of organizational partnerships. We work really closely with now 43 Indigenous organizations across Vancouver to ensure voices are being heard by the people that they are supporting at each one of those organizations. In particular, I mentioned the Dudes Club. We work really closely with them and have taught them skills to utilize. The Dudes Club is a men's organization that supports Indigenous men's health. People who are formal lived experience, who have overcome or are in remission from substance use and are now looking for ways to continue to grow their employability. We support them in all of those actions. Surveying, we have hundreds of survey participants here within the hospital and from community. We design workshops so that Indigenous patients, participants, family members can actually provide feedback about the brand new hospital that we're building. How can you see yourself in this? How are you going to feel safe when you actually are in that new hospital? We've now started applying those design workshop feedback pieces to the current services that we are providing as well, because it's valid for both. Focus groups, different areas. We work really closely with a number of Indigenous physicians from across the province, Indigenous nurses, Indigenous health professionals, to ensure that services that we are providing are improving from their perspective as well. We're coming up with an interactive portal that allows Indigenous people who are comfortable with web presence to be able to go in and provide feedback and or see what changes are happening, so that we are accountable and sharing accountability around what they're asking us to do. Advisory groups. We have a number of Indigenous advisory groups. We have a number of Indigenous people on the board as well now. And we participate in a number of health fairs across the region. Whenever we're asked to come out to be a part of these health fairs, we ask those groups what they need from us before we come out. We don't come out with a set plan. We create our plan around what they've asked us to provide. And the latest is the medicine walks. The people that feel the most marginalized coming in for healthcare are Indigenous women. And so we wanted to provide a really safe space for Indigenous women, trans women, LGBTQIA2S+ as well. These spaces are an area where Indigenous people can come and learn about culture that they've lost. They learn about natural medicines that are in the area. And they learn about culture, hear storytelling from Musqueam, Squamish, and Tsleil-Waututh elders and knowledge keepers, as well as Away Nation knowledge keepers, because many of the women and people, Indigenous peoples that are being affected by healthcare and or disparities are from Away as well. How you do the work is just as important as the work that you do. Reconciliation needs to be a factor in everything going forward. Like I said, here at Providence Healthcare, we've embedded this within everything that we do. Reconciliation, the mission and vision and values, our ethics principles, sustainability, person and family-centered care. So at this point, I'm going to stop speaking and see if anyone here has any questions or has any ideas about what they can do. What are your ideas after hearing this discussion?
I think I'll go first then, if no one else wants to go first. Thank you for that. It's really, really insightful. One thing it did bring to front of mind is I learned about from a pain specialist. It was about the biopsychosocial model of pain, where they're actually bringing the social aspect of pain and how your social environment can actually exacerbate pain. And I think that it's really going through all of these, it's really interesting that now there's this awareness that it's your social environment doesn't just actively affect the care that you receive, but the care you receive can influence the way that someone is actually feeling pain. And so situations can exacerbate a person's experience even more than expected. So I just thought I'd share that thought, and how it's watching this has kind of sparked that in my mind.
Yeah, Ben, it's interesting that you say that. I mean, I speak about the woman who was here in care for 65 days, was only offered the opportunity to clean herself twice, and was only able to wash her hair once in 65 days. How does that feel when you can't feel clean, right? How do you heal in an environment where everything around you feels dirty, or that people don't care enough to actually offer you those basic care needs? We also spoke with a number of patients that found during care exchanges, so people who actually had substance use disorders that were in some of our mental health units, were left on commodes, had to go to the washroom, were left on a commode changeover in staff happened, and they were left there for over 7 hours, unable to take themselves back. People who were left in dirty bedding, they had, weren't helped when they needed to go to the washroom. You're recovering from a surgery and you're lying in your own feces. It's not okay. This isn't care that should be happening to anyone, right? Many of the patients have also stated things like, one of the statements that stands out to me is, it doesn't cost anything to be nice to someone. To even have to say that simple of a statement from someone who is receiving extremely poor care, it is an ongoing thing. This hasn't ended. This is, the patient journeys that we're talking about are happening recently. Many of them that I speak about have happened within the last 6 months. So much still needs to happen. And this is happening throughout society. Any other questions or comments?
Hi.
Hi.
I don't really talk about this a whole lot because we're kind of taught to be a little quiet about it. I'm Mi'kmaq, so we're part of Algonquin. We're far east. I'm from Cape Breton. My family's from Newfoundland. We're all white passing. It's just, you look up a Mi'kmaq person and they're all, like, if you saw them in the street, you probably wouldn't assume they're Indigenous. It's not something I really talk about, but for me, I'm non-status because you have to actively live on the reserve for them to give you status. It's kind of sad. But living in Calgary, having non-status on my identity, the way I've been treated, my brother doesn't. He doesn't have non-status on there. He doesn't have anything related to being Indigenous or Mi'kmaq on any identifying papers. I have been treated totally different by the health system than he has. My mother, she has nothing on her papers or anything that says she's non-status either, because she made that decision. And the way when I was 14, I was misdiagnosed with a migraine when I actually had a stroke. And they made me wait about 8 hours. And my brother, he had a small cardiac episode because of too much caffeine intake. And they saw him in about 30 minutes at the same hospital. So I've experienced this, and I look white, but as soon as they see it, or you mention being Indigenous, their demeanor totally changes. And I'm honestly kind of scared. Like I've had people tell me, just take your status off. Just don't tell anyone that you're Indigenous, because it's dangerous to tell people that, especially like back east with the RCMP, definitely do not tell anyone you're Indigenous. Everyone's like, no. That's the reason why people just don't live on the reserves and stay away, because it's so dangerous. But yeah, I just wanted to share that because I had that experience. I've had that experience. Thankfully, I've got a good doctor now, so we're all good. She's awesome.
Reb, thank you so much for sharing that. I know that can be difficult as well. It continues to happen. I wish I didn't need to have a job here in this role. I really, truly do. My goal in all of this is to no longer need to have a job, to work myself out of a job. We're making steps. We have started to hear some positive feedback about different actions that are being taken here within St. Paul's Hospital now. The Dudes Club, one of the organizations we work with, has actually provided feedback from patients that they work with that they bring into the hospital to state for the first time they've actually felt respected, or for the first time they were being asked questions that allowed them to feel safe. While that's just scratching the surface, the work continues to need to be done. So thank you, Reb. I understand, your pain in that, with the many experiences that we've seen and the many experiences that my family has experienced as well.
I wanted to ask an additional question that I just remembered. Do you know if there's anything in Alberta or Calgary that's similar to what you guys are doing? Because some of Sol's team is in Calgary and they're shipping us over to Vancouver for this event. So I don't know if there's anything like that here.
Reb, for my understanding, there still isn't. I know that I am working with the associations across Canada. I've actually just worked with some groups in Ottawa and Toronto to talk about the engagement we're doing in order to help them start to do that with all of their facilities. And I've started conversations with some groups in Winnipeg and across Manitoba as well. Alberta has not reached out yet. We're hoping that, and I used to work in Alberta healthcare as well, saw and heard multiple stories that were not great. We're hoping that along the way, what we're doing out here in BC continues to push across the country as well. So I'm sorry that isn't available to you yet.
No, it's good that you guys are just starting it. It's good that something's happening. Thank you.
Thank you. Any other questions or comments?
I might just share I grew up in South Africa, and so as a white person in South Africa and sort of post-apartheid, growing up and dealing with that whole sort of social sphere, especially in my university years, one of the concepts that I found useful to think of and discuss as a white person is the idea of responsibility, separating ideas of responsibility in terms of backward-looking responsibility and forward-looking responsibility. And so I think a lot of people, a lot of white people in particular, I know definitely in South Africa, I'm not sure to what extent here as much, but will have the sense of, well, I'm not responsible. People will feel like they're being accused of being responsible for the atrocities of the past and will say, I'm not responsible for that. That's not on me. But it's important to think of responsibility as something that is forward-looking as much as it is backward-looking. So you can have a forward-looking responsibility without carrying a backward-looking responsibility. So you can have a responsibility to a community or to the city that you live in or to the country that you live in, or you have a responsibility to take positive steps, you have a responsibility to practice humility, cultural humility, to educate yourself, as even though you don't have responsibility looking backwards. And there's lots of sort of basic examples that you can make to sort of draw that distinction, like you would think that basic sort of someone falls in a swimming pool and you're there and you can swim and they can't swim, you didn't push them in the pool, but most people would say you have a responsibility to get in the pool and help that person get out of the pool, whatever it might be. And I think that just remembering that simple distinction of forward-looking versus backward-looking responsibility can really help cut through conversations. It's a simple tool to use for us white folk who might end up in conversations with people who sort of put their hands up and say like, oh, well, why is this on me or us or what have you? I'm not responsible for this. Let's all, because that's a very common thing where I'm from in South Africa. Like, can't we all just move on? As it is here in many places. Can't we just get over it? Like, this isn't on me. It's not about whether it's on you or not. It's not about whether you did things in the past. It's about your forward-looking responsibility. So, yeah.
I appreciate that, Paul, and thank you so much for sharing that. It is something that is similar here as well. We often hear people saying, well, that's not my responsibility. I wasn't a part of that. I didn't put people into Indian hospitals or Indian residential schools, right? But the racism that continues is a part of that. And it continues to be experienced. So anytime that people can step up, it's so important moving forward. Anytime somebody can learn something about another culture, another race, so important, absolutely. And I think I've stated a few times, kind of understanding the experience, it's allows for that compassion. Why can't people just be nice to one another? Right? Thank you.